Welcome back to this first plenary session of the Rhythm Interventions Online 2023. And thanks, Gerhard, Melanie and Lucas for an amazing and really interesting discussion. We've got a great session in store with a live case, future options for AF ablation for AF patients, one-stop shop PVI and LAAC from Julian Chun, Boris Schmidt and Stefano Bourdillon at CCB Markus Krankenhaus, Frankfurt. Before we join our case centre, who are already waiting for us, I'm delighted to welcome our fantastic panel. Andreas Metzner from Hamburg in Germany, Devi Nair from Jonesboro in the US, and Ariane Sultan from Cologne in Germany. Welcome and thanks for joining us, guys. As with every session at Rio 2023, we are live, so we want you to get involved by submitting questions to us, and we'll address as many of them as we can. But without further delay, let's hand over to Boris, Julian, and Stefano in Frankfurt.
So, hello, Richard. Hello, everybody. Welcome to Frankfurt. We welcome you at the Cath Lab at CCB to present the live case during Rio 2023 to you. We would like to introduce the team first. Of course, you know Julian, who will help me with the case. Then in the background, the modest Dr. Bourdillon, Stefano Bourdillon, who has been working with us for many, many years, and he will help us with the TOE during the LAA closure procedure. And then our nurses, Janina and Silke, who are supporting this case. We are dealing here with a 74-year-old female patient with paroxysmal atrial fibrillation. She has a CHA2DS2-VASc score of 3, and she was delighted when we presented to her the opportunity to undergo a concomitant PVI and LAA closure procedure using the PFA system and the Watchman Flex. So, do you want to introduce the scenario, Julian?
Yeah. Okay. So again, also welcome from my end, and we will try to do the best to make it look very smooth, but we will see. So the patient is sedated. We have excellent support from our nursing staff, and she is a combination of propofol, midazolam, and fentanyl, which we will deploy whenever we expect pain and a little bit in advance. And she's breathing spontaneously, but she will not remember what we did today. Apart from this, I think Boris already did, and you can see this, maybe already did 2 punctures in the groin. And we have a non-steerable SL 8.5 sheath, which we use for guiding our catheters. And we like to perform selective angiograms in order to understand the patient's anatomy. And this is what Boris already did. We will go over this in a minute. We have a landmark catheter in the sitting in the CS, which is also recording. And here we may also have a look to the ECG. Patient is in sinus rhythm, and we are happy to use the Cardiotech system here, which is giving us nice signals for the coronary sinus, but also later on in white, the electrograms from the PVs detected from the FARAF catheter later on. So maybe you want to go over and show what you did, all right?
Yeah, maybe could you show the X-ray right now? So here, actually, you see the PV angiograms. We are working in 2 standard angulations, which is RAO 30 degrees and LAO 40 degrees. And we start the selective angiogram at the right superior PV right here. And you can see it's a really, really big right superior pulmonary vein. Maybe you can go to the LAO. Wow, this is a really, really big vein. And we continue with the left superior and an RAO, then LAO again for the left superior, go to the left inferior, and finally to the right inferior. So I think 3 out of 4 veins are normal sized, but the right superior is quite large. So maybe we can have a discussion in the webinar on which catheter size you would choose for this particular patient. since we are planning to do a LAA closure, our standard for additional imaging on top of TOE is a selective angiogram of the LAA. And we perform this in an RAO 30, 15 cranial, and 20 caudal. So 2 different views to the LAA on top of the TE, and we can do this now.
Why don't you show it?
Yeah. Show me the
Supposed to go
X-ray,
right.
please. And now we see the X-ray. We have changed over to a pigtail catheter that is now inserted in the LAA. This is the caudal view of this particular left atrial appendage. And maybe, Julian, you can go to the cranial, and we repeat another angiogram.
And we did this already as a reference, or you see here, just have a look on this, what we stored here, the caudal view, now we moved over.
And this is the cranial.
Oh yeah, that's nice.
Beautiful injection.
Oh my goodness.
Very powerful injection.
Strong guy, don't forget. Okay, let's move on.
Yeah, let's move on. So now we keep this angiogram stored for the closure procedure later on, but we start with the PVI.
Perfect.
And for this, we will now exchange the regular transeptal sheath for the so-called Farah drive sheath, which is a steerable sheath with a 13.8 French inner diameter lumen and a 16 French outer diameter lumen and a transparent shaft that helps us to navigate the Farah wave catheter through the left atrium. Okay, let's take out the piggy and put in a guide wire for the exchange. We have already applied 10,000 units of heparin at the time when we punctured the groin. So currently ACT measurement is running. We like to have the ACT at
Wonderful.
at 300 seconds.
Maybe you can just comment, you introduced the wire into the left upper vein, of course, based on your great memory. You exactly know where it was, right?
Yeah, I knew. Well, yes, we usually do it in RAO, and we clock the sheath a little bit to orient the sheath towards the posterior wall, and usually the wire slides along the posterior wall into the left superior vein.
That was a wonderful maneuver.
Yeah, thank you. I learned it all from you.
I'm still amazed how you do this.
No.
Oris, can I ask a question?
change it
This
here.
is Devi.
Oh, Devi, how nice to hear you. How are you?
I'm good.
Yeah, sure.
So,
Go ahead,
a
Debbie.
quick question. Where do you plan your transeptal? Do you plan for concomitant cases for where you plan for Farapulse, or do you actually focus more on the appendage closure? Or is it just the same?
Yeah.
Yeah, that's a very fair point. I think so for our Farawave cases, we orient our transeptal puncture rather central to anterior as opposed to posterior punctures when we do RF procedures, because the sheath and the catheter need some space at the septum for proper manipulation and positioning of the Farawave. So we like to be anterior or anterior to the mid of the septum, which is actually in line with our puncture site for the Watchman procedure. So when we started doing Watchmans many years ago, we always oriented ourselves rather posterior, but we don't do that anymore. We like the central to anterior position for the Watchman procedures too. I don't know how you feel about that.
Well, I think that's kind of what we're seeing as well. We're doing more inferior anterior or inferior mid punctures for our appendage closures. Majority of the cases, especially for this particular anatomy, I would think so.
Yeah. So flushing the Farah drive is very important. It's a big lumen, large bore sheath, so we like to be very careful to really get all air out, orient the flush port to the ceiling, and keep the sheath up a little bit. Now flush it for the continuous drip. We use a syringe pump to continuously flush that sheath at 20 cc's an hour with heparinized saline. And we, of course, pay really attention to this transparent shaft, that no air bubbles are visible.
Maybe you ask with the question what
Yeah, dear panel,
what catheter you would select.
which size would you have taken for this case? We've already selected one, so.
Maybe I can start. Here's Andreas from Hamburg. Hi. First of all, good to see you. And
Hey, Andreas.
I'm really looking forward to an interesting case. I've also seen your angiographies, and I have to admit, at the very beginning of our PFA career, we always adapted the size of the catheter according to the PVs that we've seen. Although I have to admit, this right superior PV is big. However, I would probably still stay with a smaller catheter with 31. I think this diameter of the PV is a maximum 25 or something. So we are far bigger with the PFA catheter still. And I would certainly stay with the 31 since it's easier to maneuver it. It's easier to especially get it in its shape in front of the right inferior PV. It's a little more difficult with a bigger one. And also, according to the results from your center, I think durability is better when using the small one. So that are, I think, two arguments. It's first of all the fact that the PV is not too big, and secondly, durability is better.
Very strong.
Yeah,
argument.
hi, here's
Yeah, it's a fair point.
here's Ari from Cologne. Thanks for having us, and congrats to the great case. I couldn't agree more with Andreas. I think the risk of touching the rest of the left atrium and causing some additional lines that you don't want to do. If you look at your data, you have shown us nicely the rate of consecutive atrial tachycardia arising from isthmuses that we might create bigger devices. I would also go for the smaller one. And we're talking about 3 veins that are more or less normal, as opposed to only 1 vein, which is a bit bigger. So therefore, I think it's completely fair to say to use the smaller one.
All right.
My
Okay.
experience is
So
only
this-
with Advantage, and it's I would say 31 too.
31. So what
God.
did we do?
Now I feel bad. We never do what we're told to do. So, based on the angiogram, we are under the strong impression of that right superior monster PV. So we chose to go with the 35, and maybe it's a good. I mean, you all addressed very fair points. You had very good points in selection, and I am sure that with a 31 you would have done the case properly. But on the other hand, maybe we are able to show you some maneuvers, some workarounds that we developed during our experience that allow us, even with the 35, to get a very good ostial PV isolation and hopefully also durable PV.
And also on top of this, maybe besides of positioning, we may also have some time at least to discuss if one should do more or not. This is something we will see on the way.
So could you open it up can you show the catheter again, a close-up of the catheter? So now Julian will open it up to the flower. I have to, keep it really straight. Sorry for the camera now, okay. Okay, so now we have it. You can see that the catheter now is in its flower configuration. It's a 35 millimeter diameter catheter for very large lesions around the PV. And I'm pretty sure it will cover this right superior vein too. Maybe, I don't know, Stefano, if you're able in the X-ray, if you're able to measure the diameter, because Andreas said it was 25. My impression was it's a little bigger.
Just very quickly, the preparation of the catheter, because I'm sure not everybody would have used it already, is pretty straightforward. It comes out of the box. It's got 2 ports. One is the inner lumen for the guide wire. It is the so-called inquire guide wire, which has a pigtail configuration at its distal tip, and it combines good stability, but also, let's say, some soft mapping abilities. And then we have a second port, which we connected to a flushing line, and we allow continuous flushing and dripping of the catheter. Yeah, and this is basically it. And there's the option using the slider, which you may see like here, and the slider allows changing the configuration from the flower seamlessly to a basket and vice versa, and the other way around.
Okay, let's introduce it.
Good. Pulling back.
Okay, I introduce the catheter until I can see it in the shaft. I see a couple of air bubbles here, so I need to repeat my flushing, keep it up, and suck with the syringe to get them all out. And yeah, that looks better now. Okay. Now everything is clear. Could you please advance the wire?
Sure.
And now can you show the X-ray for Andreas? Of course, it's difficult to see. We're in the lab, and it's 31 or 30.5 millimeters. So really, really big vein. Okay. Now we are in the RAO, and Julian has advanced the guide wire into the left superior
For
vein.
a short moment, maybe show it. We open up the window a little bit. The fluoro one more time. Just hit it. One time.
One more time.
Yep, you'll
And
see
maybe can you show the still image of the left superior? That was number 3, I think. The X-ray number 3 that you filmed. Okay.
Otherwise,
just,
I can play
next to each other, so we can show it to the audience.
That's nice. Wonderful.
Okay. Now we have already introduced the catheter into the left atrium, and we now need to open it up. And for that, it is important to keep it in the left atrium to give it some space. So I now pull the slider, and you see it's opening up to a flower, and then we can advance towards the vein, put some pressure on it. You see that now the splines are not. Are they? Yeah, now they're fully open.
A little
and
better.
they interact with the
Guys,
tissue
may
when
I ask
when
something?
push it.
Bin mir nicht ganz sicher.
Yes, of course.
So since you
Sure,
know that
David, go ahead.
aside from the right superior vein,
Oh,
the
and this
other
Ari.
veins are quite normal. Would you keep the basket smaller than you would use for the other veins, or do you still have the same size of the basket?
Absolutely. We would go for a little bit smaller orientation of the basket, and we will also show you 2 additional applications that we call the olive, which is a very small basket inside the cuff of the pulmonary veins. So this we will do like after the 8 applications. Now in the image you see the baseline angiogram in an LAO, and you see the RAO now, the actual position. And maybe now, instead of the still screen of the X-ray, you can show the electrograms, the cardiotech. Beautiful. So you see, of course, the surface ECG, and then you see the white electrograms are from the Fairwave catheter, 5 bipoles. And then in green, you see the coronary sinus catheter.
Do you want to pace one time? In order
We could pace. Could you pace from CS12 at 600? Just to separate the far field from the PV spike. It's not capturing. Now it's capturing. Yeah.
It's nice.
Nice to see. Maybe take a snapshot, and we will compare it to the rest later on.
Good.
Do you want to turn around the GUI to show
We
the GUI?
have the. I was told we have the information right from the console, from the GUI. So the GUI, this is my turn. I'm very happy, and I prepared myself to use the GUI. So it is basically what we did. We put and set the voltage as the default to 2.0 kV, and then basically I can hit prepare, confirm, and deliver, and I have to count the numbers, because we want to give a certain number of applications per vein. And from my end, I would be ready to go for it.
Let's go.
Then we say prepare.
Do you guys give any atropine or something?
Yeah, we did deploy atropine. That's a good point, because we know, of course, there could be an impressive vagal response for a short lasting, maybe sometimes a couple of minutes lasting. But with atropine, there's no need to reposition the former CS into the RV, and therefore we do deploy also as a default nowadays atropine. Okay.
Okay, let's go. Let's go. Let's look at the electrograms, and now we apply the first set of pulses. Wow, and this is an impressive effect. You see on the still screen on the bottom, you see the before and after electrogram setting. We apply another one before we turn the basket a little bit to reorient the splines, to cover the whole perimeter of the vein, and to have contiguous lesions at this PV. if you look at the live electrograms, of course, you can be intrigued by the, let's say, small amplitude fractionated electrograms. But don't forget, we are dealing with large electrodes and a large distance between the also a large spacing, inter-electrode spacing. So we pick up a lot of far-field electrograms.
Okay, let's move on.
Let's move on. I do Ariane. Now what I do now, I push the slider a little bit, and you will see it's moving into the cuff of the vein. The basket is now much smaller. We call it the olive, and that is, we are trying to mimic what you do if you cannot isolate the vein, the lateral veins, with, let's say, point-by-point ablation. Usually, you go onto the venous side of that Coumadin ridge and ablate it one more time to isolate the vein. And this is what we do with these two olive applications.
For the flower now.
Now I open it up completely to get a flower, and I push it with my sheath in the center of the flower, and you see the splines are flipping backwards, indicating good contact to tissue. And
see it again here.
Please keep the sheath in the same orientation as the guide wire to align the catheter with the axis of the vein, and this helps you to really get a proper lesion. Okay.
Boris, may I ask another question? First of
Yes,
all,
please.
it's a very elegant way of isolating left superior PV. Another question, you mentioned that you do the procedure under propofol, which is the standard in Germany. Is the sedation level in a PFA procedure different from cryo or from RF at your center?
Yes and no. So I think the total amount of sedative drugs that we are applying is very similar to ablation procedures with thermal energy, because the procedure with PF is so short. However, maybe the peak dose is sometimes a little higher because we deliver a little bit of propofol and fentanyl before we start the energy delivery. But you might have seen that the patient is really, really calm now. She's not moving at all. In the interest of time, we move on to the left inferior. Okay, so we have it in the flower. We always manipulate in the flower and pulling back the guide wire and then orienting the catheter. Now, one of the splines is prolapsed into the vein. You see, in the RAO, I need to rotate my sheath in a clockwise fashion, rotate the catheter a little bit. Maybe open it up a little, like this. Okay. So now all splines should be out. Sheath again in line with the wire. Let's reconfirm in the LAO. Yes, nice position.
Also keep an eye on the signals.
Yeah.
Just to appreciate the spike in that inferior PV.
Yeah. Take one more snapshot for the pre-post large PV spike, which is gone now. And we continue with the recipe. 10 applications per vein.
I move it up to RAO again.
Okay. Now I have three splines up, or 3 petals up, 2 petals down, to really cover the whole perimeter of the vein with my...
One more with a flower, and then we change.
Okay. I think the most
Very
interesting
beautiful,
part
guys.
will come...
With the olive, do you do a turn between the two olives as well?
No.
Okay.
So this is the basket.
Now, beautiful basket, Dr. Schmid.
No, we feel it's a lot of energy deployed at this anterior part of the Coumadin ridge, so we feel it's enough, but we have not yet scientifically validated that concept. I mean, we, as you all know, the durable isolation rates between the initial reports and the single center reports differ very much from the multi-center reports from Euphoria and from Advent. So I think there's still some room for learning in terms of dosing and in terms of manipulation and positioning of the device. So this is now 8.
Yeah,
we go now for the olive. Let's make it smaller. It slides in. You need to make sure that the electrodes are not too close together. I think it's not too close.
Yep.
Yeah, that's better.
That's the one. That's
Yeah,
the one.
That's good.
Beautiful.
All right.
So we've been given a question from the audience. Do you do the olive even if you're using a 31 millimeter catheter, guys?
Absolutely.
Yes,
yeah.
we started using this concept with both catheter sizes. Can you come back with the wire?
Yeah. And let's play the angiogram before,
yeah.
right?
Let's
I can play it and maybe more easy and faster. Here we go.
This is the most difficult maneuver now coming over from the left inferior to the right inferior. Again, we will use the flower configuration with the wire completely pulled in like this. I pull back my flower, I bend my sheath, and now I think we're not in this inferior. I need to come back with the wire again.
Wire's back.
Here, that is better. Yeah.
Wonderful.
Now we're in this horizontal branch.
I'm a cross track.
Of course, petals are still prolapsing. I think we have too much pressure on the catheter with the sheath. But as you can see now, this is a good image for an explanation why we are using an anterior transeptal puncture. You see the curve of the sheath is rather an F curve than a D curve, and you really need that space to manipulate the Fairwave catheter. Oh, now we lost the wire. Okay, this is something that should not happen, but we can. This is hopefully
Still the upper branch.
Yeah, come here.
A little
Yeah,
more,
here.
A little more down.
Okay, and of course now we of course do see what Ariane and Andreas referred to, that manipulation of this large catheter at the septal PVs can be a little bit difficult. Now there's still a prolapse into the vein. Let's come back a little bit, give it more space. I try to maneuver it.
But come back with the wire.
Come back. Yeah, here it is. Here's okay, I think. Let's use that super branch.
Yeah.
Let's see. Okay, pull back again a little bit.
If you want me to give you the R
Yeah. We need to.
Yeah.
Now we are. Show me the LAAC.
Does it ever help
Where are we now?
to
Is that
go
this-
into a basket to orient it better sometimes, especially for the right inferior veins?
Yeah, it can help. Sometimes I do that. That's true. Now, on the other hand, I would like to see now all petals flipping out off the vein to be really outside. So now this is better. I know one is still prolapsing. So it has. Oops, we always lose the wire. Now we're in the superior. So Ariane and Andreas were right.
But easy could be, I mean, we wanted to show something more difficult, of course, and challenging. But maybe it's a good idea what Debbie just said, going in a little basket and then doing the other way around.
I can try.
Yeah, exactly.
Okay.
We can just have a look to the other. Yeah, it is definitely the inferior vein because it runs really posterior with this direction.
Okay. This is
Again, look at the
acceptable.
beautiful signals we
Okay,
have.
let's start
in
with the
cardiac
basket.
Yeah, looks
Why not?
nice.
Yeah.
And
I think-
indeed, I mean, you see, I still have some difficulties.
Can you show
in positioning
before and
the
after
flower
again from this one?
appropriately?
Oh yeah.
And so if I cannot achieve an appropriate position, sometimes I also decide to go with basket configuration only and skip the flower. So, I mean, it's not mandatory to go with the flower. It's desired, though, but yeah, it's not always perfect.
Boris, why?
But I think it's a good example. Yeah.
Sorry, Boris, presumably the petal prolapsing into the vein just means that bit of the antrum isn't covered because you're not worried about ablating within the vein because of the real safety data. So why not just do the flower anyway to cover some of the antrum?
Yeah, that's a fair point. The only thing that you need to consider then is that, of course, you're ablating a wide spectrum of the antrum, and you leave sort of a corner of an area open, unablated. So will this contribute to higher, let's say, focal arrhythmias? We don't know. But indeed, we need to turn it around one more time. The basket, yeah. That would be an option too.
Well, Boris, maybe
we have
another
an,
comment. You're still concentrated, Boris. Maybe
yes.
just one comment. Something you do very automatically is that you just move the catheter while being still open. And I think that's something we really had to learn. I have to admit, at the very beginning, we did it as we were told by the company, always to close the catheter and open it in front of the next PV. But what you did automatically to turn it in an open shape makes it much more convenient, because the challenge is most of the time the right inferior PV and to get, as we have seen here, the normal shape in front of the PV, and it's facilitated by keeping the catheter open while turning from lateral to septal PVs.
Yeah. That is our standard way of manipulating the catheter in the left atrium to keep it in the flower configuration, because this also protects the sheath and avoids or prevents perforation. Okay, this is now the situation that Richard addressed. One petal inside, but the others are covering nice. Oh, we have already done 30. Okay, that's fine. So we go to the right superior, this monster vein. Okay.
You want to...
Let's do it in the LAO 40, maybe.
Yeah. Alrighty.
And we show the angiogram again. Maybe this was the second
Here we
one
go.
here. Wow,
Right.
This is a big one. Okay.
Good.
Let's try to go there.
Wonderful.
Okay,
Come back
with the wire. I go counterclock. And the catheter is not fully open, but yeah, okay. Now we are in.
The wire runs in very, very easily. We have seen the roadmap basically beforehand.
So now, this is now really large enough to cover that vein. I think we need to come back a little bit more. Turn it again. And yeah, I don't know if it's feasible to really completely be outside that vein.
What we can show all of them again is
look at this.
The RAO angiogram, because you will see in the RAO angiogram how large and how, already, let's say, very, very antral you are. In fact, it's of course you can discuss all of it, but here you're really covering the entrance of the vein.
Yeah. This is the RAO image. This is the LAO. I think it's acceptable for that size.
If you want, go ahead.
Go. Electrograms disappearing.
And Boris, since this ostium is so big, would you consider doing a sequential basket approach after having done the flower to cover a little bit more an ostial part of the vein?
Beautiful.
Yes, we will of course go with the basket. As for the other veins, we will. Let me just orient this. Is that okay? That should be okay. Yeah. We will do one regular size basket, and then we will do the so-called olive again. One more, right? One more flower. And then
one of the tips.
And congratulations, you proved.
Sorry, one of the tips that my anaesthetists have told me is that atropine can sometimes cause confusion in the elderly, so they use glycopyrrolate as the anti-vagal drug.
Okay, that's a fair point. I was afraid of patients with prostate hyperplasia, that they can't urinate after the procedure, but we haven't seen this yet, to be honest. And I like to apply only 0.5 milligrams of atropine, which is usually enough to mitigate the vagal responses. One more.
Did you guys consider to put the CS catheter in a ventricular branch, for example?
Yeah, you're right. It came out during manipulation of the catheter. But you can see
Look at this.
Yeah, this olive looks nice. I think we did not run into any Brady position. It is safe here. Of course, we could spend a couple of seconds to reposition it, but
The only reason why we keep the CS catheter is that for orientation during transeptal puncture. Our friends from Lübeck, they have introduced the fast and furious approach without CS catheter, just a single catheter procedure. It seems to work well, and something that we could consider to do.
maybe in the meantime, while we may discuss also different ablation strategies, we are now getting ready to move on with the next step. And maybe you just briefly, or we can also briefly comment on the electrograms now. You see, it's a nice olive, and it is right in the vein. There's no signal, as you can see on the cardiotac. So therefore, the vein is beautifully isolated. And Stefano is now preparing the TEE, and we have been looking already at the different sizes of the left atrial appendage. And now left atrial appendage here, I will play it again. This is the RAO with a cranial. Oh, I'm sorry, this was the caudal view, caudal 20 degrees. And the next one was the cranial RAO 30 and 15 degrees. And we always eyeball because we know that the piggy has 15 millimeters, so it is definitely more than 15 millimeters, maybe 20 plus. So, but in order to have at least additional information with regards to potential sizing, we do, of course, measure the appendage in both angulation. This is what I'm doing now. And you see here, now maybe, you see it here. I did measure, and here we have like 23 millimeters. And I go into a different position again. Here it's a little, let's say, a little bit bigger. It is 23.6. And if you go a little more distal, because the circumflex is somewhat in that area, we are here, look at X3, so it could be also a little smaller, around 20 plus. So this is the cranial angulation. Okay, so we keep this. We do remember this one, and then we go back to the caudal, and here we do again measurements of this.
So while you're doing that, Julian, I'm going to ask your poll question to the audience. And while I'm doing that, I'm going to ask you guys to think about if you got rid of AF, would you need to use anticoagulation or an occlusion device? But I'll let you think about that before I ask the audience your question, which was, what would be your favorite antithrombotic strategy after a concomitant PVI and LAAC? Is it A, NOAC for 8 weeks, then ASA, NOACs indefinitely plus ASA for several weeks, NOAC plus ASA for several weeks, then just ASA, dual antiplatelet therapy for 3 months, or single antiplatelet therapy only? So maybe, audience, you can answer those votes, and maybe I can ask you guys, why occlude if you've already cured the AF?
Yeah, that's a fair point, but when we're talking about our success rates for AF ablation in a traditional fashion, meaning the 30-second rule, so we are, for patients with paroxysmal AF, we're around 80% in 1 year with PFA procedures. That's been published from several studies. In Advent, it was 74%. So there's still a considerable number of patients who still experience AF recurrences. That is number one. Then we don't know what is the result over the years, so the long-term results might also be different, and they are certainly not higher. So I still believe that a eternal stroke prophylaxis, as it is with LA closure, makes complete sense. And in patients who have a CHATS VAS of more than 2, I think it is an appealing strategy to prevent stroke even after a symptomatic AF treatment.
Boris, can I ask a question about the
Wanna
measurements?
go for it?
I know you did the angiogram in the beginning, and traditionally with RF and concomitant cases, we always see edema and swelling along the ridge, and then the measurements are very off. Is that something that you notice with PF as well? And are you basing your
very good
sizing based
point.
off that?
Yeah, Debbie, that's a very good point. And Stefano was also listening. And in fact, we have observed exactly this phenomenon a couple of times. And maybe it's a good chance really to look live into what we see now in the TEE. Maybe we can switch to the TEE, and Stefano can comment on this.
It's a very nice comment, and we also observe some kind of swallowing of the ridge between the LSPV and the appendage after ablation. We observed first with the cryo, and we thought that maybe with the PFA we would have observed something different. But indeed, we can see here, I hope you can see the echo picture, that the ridge between the LSPV and the left atrial appendage has clearly some edema after the ablation. Fortunately, it's so proximal that I think it will not impact our measurement for the sizing of the appendage. I am ready with the TE.
Yeah, okay. Let's go and screen and make some measurements. And the TOE, Stefano, it's your show now.
We always try to measure. I have to say that you choose quite a big one. So we have here quite a large left atrial appendage. We always measure in 3 different planes. So the 30 to 50 degrees is here. And you can see here that we have the circumflex. So once again, I can show you it live. Okay. We have the ramus circumflex here. And if we measure from here, so the ostium is already quite big, but we don't want to implant here. I think that, Boris, you agree with me, we will have something, a landing zone, something like that. So in this plane, we have something like 25 millimeter diameter. But obviously, we can also choose to implant it deeper, and then we can have here 22 millimeter landing zone. If we go to the 90 degrees plane, to say it's not so easy to have a good visualization of the appendage in this patient, but okay, we can have it here. And once again, we have our ostium of the appendage that's here, but probably our landing zone will be something here. Boris, do you agree?
Yes.
So 22 here.
That matches well with the
I'm not measuring the length because we don't have problem with the length of the landing zone. No. It's a very big one. But if we go to the 135 degrees, the third plane that we want to see, here sometimes we see some kind of trabecularization, some kind of splitting in multiple lobes, okay? And here it's much smaller, I have to say, okay?
It's tapering down, yeah.
Yeah, because here, if we go here, we have 17 millimeter. Once again, our ostium is much bigger, but the landing zone is probably so saving 17 to 18 millimeter. So we have a measurement of the landing zone that are ranging between 18 millimeter and 23 millimeter.
Okay, so hey, we have device sizes of 20, 24, 27, 31 millimeters and beyond. What would be the best choice here?
I mean, I could start if you want. Since you choose really a tricky case, first of all, congratulations to the very elegant pulmonary vein isolation. You proved me and Andreas wrong. So if you're skilled, you're able to maneuver a bigger catheter in the left atrium as well quite smoothly. Having said that, for the left atrial appendage, I think it's a tricky one because I think you're ranging between 27 and 31 millimeter in device size. since the largest management you had measured is something around 24, 25. In this case, depending on your landing zone, I might opt for the 31 millimeter device.
I agree with
You like
Darian.
31?
I think I would go for the 31 too. And mainly because I think, with the fact that you talked about the swelling, I think you might get a really good occlusion with 27 now, but long term to avoid leaks later on, maybe a 31 with a little more compression might be a good idea. I'm always curious too about the olive lesion, whether it affects the appendage ostium more distally, not just the Coumadin ridge.
Yeah, and do you agree with me that the LAA is really tapering down like an ice cone, and I'm a little afraid that the 31 might be too large for the distal parts of the left atrial appendage, or are you not worried about that?
I'm not worried.
Yeah.
Go ahead, David.
No, I was going to say it might be a little more proximal device, but I think if you have a good skirt covering, I think you won't go wrong with either. It depends on where you place the device. It's a big appendage, and I've always been one of them that tries to fill the appendage, not leave much room distally, to allow, because I think with the flex, we have to worry about the device moving distally as well, which is not a problem in this case, but I try to fill the appendage with the device when I implant these.
Yeah, I agree. I mean, also, I don't know what the volume status of the patient. You use PFA, so I don't know when was the last time she had something to drink and if she got some volume overnight. So the left atrium might not be expanded fully. Also with the edema, as you said already, I would rather opt for the bigger one. But I see you guys
Ladies and
are
gentlemen,
thinking of
we
the
now need to come to a decision because we have a couple of minutes left, and I think all very, very valid points, and we will have to decide. So
I would love to go with the 27, to be honest.
yeah, me too. For the aforementioned reason.
I'm not as courageous as Stevie and Ariane.
Having more options, also covering the more, let's say, the tapering down of this ice cone LAA, and so that's good. I mean, it's a little. We did not follow all the advice from this great panel, of course. Let's see how it works out.
I mean, you're sticking with the theme, so that's good. But I think you're good either way. I think the device does give the flexibility to go between sizes, and there's such an overlap between sizes. So I think you can't go wrong. It depends on where you implant, and you've shown us great skill in PFA. Can't wait to see this.
Yeah,
no. While you're prepping the device,
you're right.
Yeah, I was just going to say, while you're prepping the device, I know you guys are using the Watchman Flex device, but I think for once we actually got lucky in the US, and we actually have the next generation, the Pro device available. It's just commercial now, so it's a coded Watchman device, which kind of is on the Flex platform, behaves the same. So it's coded, and hopefully we'll see less DRT with that.
Okay, good. There we go. All right. So we already brought in the device, and we changed fluoro a little bit to have better visual impressions for you guys. So you see the little ball.
Yeah, it would be nice to see echo and X-ray during this. We don't need to see us. So this is now, as you can see in the TOED, you see the partially deployed Watchman Flex here sitting at the entrance to the left atrial appendage. And I just push it and turn it a little counterclock to orient it more anteriorly. I think I'm entering now into the left atrial appendage. Can you show, Stefano, maybe is it 135? Is that a good, let's say, yeah. No, I'm still a little too proximal, I would think. Yeah. So I go in a little deeper. And now I'm in a good position with my ball. It's well beyond the circumflex artery where I would love to open it up. So just push it out, come back with the sheath at the same time, and now I'm inside. Let's see how that looks.
That's pretty proximal.
no movement of the bubbles beyond or behind the device.
Can we see the echo a bit bigger?
Thank you.
Thank you.
Yeah, perfect.
Boris, would you put that device a little more deeper since it's a smaller device? And the compression
I
looks
agree.
a little,
Yeah.
a little low.
Although, I mean, it's fully in let's say, in contact, you might be right that we can put it a little deeper. Yeah, why not?
I agree. I would also.
Yeah, let's go for
Go for a
safety
second run.
and put a little deeper in. I recapture it partially. I push it a little in, and then redeploy.
Yeah, that's better.
Now it takes a much more compressed shape, but it's certainly sitting now in a safer position in terms of embolization.
But it shows nicely the, let's say, variability of this device. I mean, a clear difference with the compression.
That looks nice.
That's,
Looks very nice.
it
Yeah.
looks great.
Nice.
Impressive.
I think this is a beautiful. Yeah. Why don't we sweep around different angles in the TEE? It's much more of a marshmallow or.
That looks like about 15-20%
yeah.
compressed. So that looks great. Yeah.
Oh, wonderful.
Should we quickly look at the results of our poll while we're admiring that position?
I can just pull it for a tuck test. I pull now the wire. It stays in the position. You see it on X-ray. Really pulling hard.
Oh, sorry,
and
what-
it stays where it is. So, sorry, Richard, I did interrupt.
Maybe they could not see it because of the poll result.
Oh, I see.
So maybe you do it again, or
we've
can
just seen
we
it.
show it from the? Yeah.
We've seen it. Don't worry.
We don't see it. So
We're
we
clever and
can.
went back.
Okay.
So let's go back to the poll. We'll quickly do that. So the most people say NOAC indefinitely plus ASA for several weeks, which is quite interesting. So that's the most popular answer, which I'm quite surprised by. And NOAC for 8 weeks, then ASA is only about a quarter of the people. And NOAC for plus ASA for several weeks is the then ASA is the third favorite option. So most people seem to have said they would continue with NOAC indefinitely anyway, which I'm quite surprised by. Let's go back to you guys.
That's definitely a very,
Frankfurt.
yeah, that's very definitely interesting results on the poll.
Yeah, it is. And now that is a question that we will address with the LAAC study. LAAC is the first superiority trial in the field of LAA closure that will start very soon, or maybe has already started in the US. This I'm not aware of. So it will take patients with non-valvular atrial fibrillation and a CHA2DS2-VASc of 4 or more, so high-risk population, and randomize these patients between NOAC therapy and closure with the Watchman Flex plus continued NOAC therapy. And the primary endpoint is superiority in terms of ischemic stroke and systemic embolism reduction in the active arm. So that is a very important and very interesting study with more than 4,000 patients in 150 centers globally. And well, obviously our audience already likes the strategy. We can do a final angiogram if you like. Let me shoot it in the RA caudal. You see that this is how it looks now in terms of X-ray. I would think nicely covered. And I agree with Ariane and Devi that the 31 would have fit too. Maybe it would have been even more compressed, more in a sausage shape, but and with more shoulder. But I'm sure we could have chosen the bigger one too.
Good.
Shall we release it?
Yeah. Why don't you set it free, man?
All right. That's
Good.
Guys, can I ask you a question? I mean, there's contradicting data out there with regard to LAA isolation. Since you already planned a concomitant procedure, would you consider isolating the LAA in the same procedure
Well, yeah, that's a good point. I think we still have conflicting data towards the role of the LAA as a driver. There are some studies, observational studies, that showed some beneficial effects in isolating the LAA, others did not. There's also a randomized study in long-standing persistent patients. In paroxysmal, this concept is less well established. So I would probably not do it in every patient. And along with these, let's say, conflicting data, there's also this thing that edema might be even more pronounced. That's the point that Devi addressed, that edema formation after acute or during the acute ablation process might interfere with the concomitant implantation procedure. So I'm not sure that this is a perfect idea.
And also we should not forget, Ari, that of course the structure of the appendage may ask for more. And then we are back again with unknown dosing. And therefore, there may be in some scenarios you may think of, but as a strategy, I think at this point in time, it's maybe a little bit too early. But definitely a very interesting concept, of course.
No, completely agree.
Alright, so
I wouldn't go
Boris
for that either.
We are now
We're almost out of time. Can I just ask you to confirm? Can I just ask you to confirm what your anticoagulation strategy will be here, Julian?
Oh, yeah. So I leave it to Boris to answer this one because it is true. It is sometimes an individualized strategy, also in our hands, and also depending on the patient's, let's say, risk profile, of course. And therefore, yeah, I have my clear idea about it, but Boris, what would you do now?
So I would continue with NOAC for 8 weeks together with aspirin. And then I would stop the NOAC in this particular lady and keep her on indefinite aspirin therapy, since she also has some atherosclerosis in her coronaries.
Boris, are you using the aspirin in addition to NOAC? Are you using the aspirin in addition to NOAC because of the atherosclerosis? Because there is data for that there's more bleeding with aspirin and NOAC.
Yeah, that's true. This lady, she doesn't have a particular bleeding risk. And the NOAC plus aspirin was the concept that we used in the option trial. And it worked well for us. We don't know the multi-center data, but the single-center data looked quite good. And so I would go with that. Of course, there's also data that showing that prevention of DRT can be achieved with low-dose NOAC or full-dose NOAC. So this is certainly an individual decision. And for her, I would like to be on the more intense antithrombotic strategy side because she has no bleeding risk.
Good.
I think we're going to wrap up this session. I'd like to thank you both for doing a beautiful case and Stefano for amazing TOE pictures, which really made it obvious to me what was going on. Thanks to the panel for great questions and comments from Andreas, Devi, and Ariane. Join us in a few moments for the next session where we're going live to Phoenix, so waiting for us there.